to start with you, actually. Not giving you much of a break.
That's all right.
But so when you, at UPMC specifically, when you come up with a plan, to implement some innovation across your health system, how do you make sure, how do you introduce it to, let's say the clinical staff, and how do you make sure that they're actually doing it, and how do you get them on board, and how do you follow up with them to make sure you do that?
So that's a great question, and there are a lot of health systems that are very innovative, right? But the approach that we take is not to start first with a pilot, right? There's this notion of pilotitis, where you're like, I've got a great solution, let's pilot it, because I'm sure then it'll prove its value out by itself. So we start first with strategic alignment. We actually sit down with our end users and figure out what their pain points are, and we engage them, as I described earlier, through this process of participatory design thinking. And I think that's probably the best way to get buy-in, because at the end of the day, it is their problems that we're actually trying to solve. So that's what we do, is we work with them right from the beginning, and that, I think, really guarantees the biggest level of buy-in. And look, if it's not working, we're not afraid to call it quits and move on to the next thing, learn from those failures and move on to the next successes.
Patti, you mentioned in your talk that you're all very open to ideas from researchers, and you would love more ideas from patient community or sort of patient advocates. So what's an idea that maybe a biomedical researcher has given the library that's actually implemented in a change, and can you come up with an example where a patient actually gave you an idea or some feedback that led to a change, or is that just something you're still hoping for?
Oh, no, we get a lot of feedback, and we do a lot. So one of the most important things is the content that we included in Medline Plus. And we're constantly getting input about that. But we also get information as we talk to groups like this about what really one can do with these enormous data banks that we have, and how do we make them useful for individuals, and not strictly for scientists. So what we've been doing in those areas is to make sure that we have available small data sets that can be explored by citizen scientists who have an interest in them. Also, we do, on Tuesdays at noon, we have something called the NCBI Minute that is a small tutorial on how to use our different resources and our different tools. The most important thing that I think we need to be thinking about right now, though, is how do we get information in action into people's hands. And so I'm really looking for ideas about how do we move from making people read everything and then think about it and then change their behavior to actually information-driven appliances, information-driven expressions, advertisements, and importantly, information-driven to the community or the cluster of people around the patient, not just to the individual person.
And Doug, I guess I'm curious to know what advice you would have for patients, maybe at the outset, maybe a little different case. Let's say they get a diagnosis, a specific diagnosis, so at the same time as they're dealing with sort of just accepting or grappling with this diagnosis, and then they're trying to figure out their medical team, and then they're trying to read up on whatever disease they're given. What advice would you give to a patient in that situation to try to, come to terms with that, like not get overwhelmed with that, and then start sort of navigating that?
Well, one of the things you want to do is realize that you're sort of going to need some kind of medical home if you have a chronic illness. So sometimes it doesn't necessarily matter which doctor it's going to be, but you are going to look for, whether it's a primary care or a specialist, somebody that you think that listens to you, that you can turn to, that you can... There's a lot of guidance on who can do what, and having a doctor who's sort of pre-decided, this is my patient. Sometimes I go out on a limb, whether it's a non-traditional dose, or whether it's ordering a blood test when usually we wait 6 months, or so finding someone who's going to take ownership and partner with you is the first step. And you can be creative about that. Like, you don't have to just go, my hematologist is the quarterback. You can have a primary care who's the quarterback. So a lot of times that's one of the first things. And the next is to figure out what level of confidence this diagnosis is. I can't watch the show House, I think the guy's a jerk. But apparently he walks into the room sure about everything, and for 46 minutes he's wrong every week. And so it's this. So as scientists, we don't have an immense surety to start with. So in the course of one day in the hospital, I had I got one test. It was very quick. I had one test for adrenal insufficiency. The first doctor came in and said, you probably have adrenal insufficiency. Your numbers were low. And 4 hours later, the next doctor came in and said, well, your level was low, but your increase was fine. You're probably fine. And the third doctor came in and said, good news. You're fine. That's one day. Now, I knew that was probably the resident and the fellow and the attending, but someone else, they would have thought all day. They would have been reading and freaking out about what their future looks like. So it's important to understand the difference between someone saying a diagnosis and something that holds up over time.
And just to go a little bit further, you know, and I'm sure you ran into this, but how would you sort of advise a patient who's trying to advocate for themselves or maybe come up with their own suggestions and they're running into just no from their doctors, or no, I'm the doctor here, you're the patient, like this is what we're going to do. How do you kind of collaborate there? The
advice that I would give a patient is actually the same thing I give a doctor, and that is to divide observation from explanation. Patients are bad at giving explanations because they're not clinicians or scientists. But that doesn't mean the observation you've come up with isn't very accurate. It could be rock solid, and your explanation for why is not overly sophisticated. So what you do is be clear. Here is what I have observed. And then you can say, I don't know if it's this. It's always better to ask it as a question. Might it be this? Than to tell the doctor what it is. Especially if you're not a sophisticated scientist or a physiologist or something. But remember this, observation and explanation are very different. And all sorts of people can have very astute observations about their own health and not be able to explain them. Being able to separate those as you present them to a doctor will stop you from getting rejected, you know, right away as putting forward, you know, folk remedies or something else. So that's very important. Here's what I'm seeing. And then you can say, is it this?
Patti, you kind of outlined some of the library's plans going forward and what you're committed to. I guess as part of those plans, can you talk a little bit more about how you're going to try to make some of the things you already have maybe a little bit more patient-friendly? You know, you talked about on PubMed how now sometimes that researchers, I think, have the options of including the data so anyone can download that. You know, I'm a health and science journalist, and I spend a lot of time on PubMed and clinicaltrials.gov, and I frankly get pretty lost in there sometimes. And so, you know, I'm, you know, truly a non-science, non-doctor patient coming into that, trying to sort that out. Like, what are your future plans looking to even make it even more sort of, patient-friendly or family-friendly?
So this is a question we get asked a lot. So remember, we're a library, and one of the purposes of a library is to create the archival repository, not necessarily to create the super-duper Amazon interface to it. So I see a tremendous need for partnerships to create better interfaces to our resources. So clinicaltrials.gov is a very good example. We have almost 300,000 different clinical trials reported in clinicaltrials.gov. About 50,000 actually have results. But to make them useful to middle-aged women in New England who have breast cancer, we might need to partner with a local organization who can download our resources every night, sort through the ones that are relevant by geography, relevant by age, relevant by even the population genomics of an area. The second thing we're working on, if you saw the New York Times article yesterday challenging the interpretation of genomic tests, which change over time as we understand the genome better, as we run different variant callers over the genome sequence, we must build a better pipeline of updating information to people. And it goes back to a little bit about what Doug says. We have to first help people understand that healthcare knowledge and medical knowledge in particular is probabilistic, has uncertainty built into it, and the tools we should display it with should be tools that reflect degree of confidence, the degree of uncertainty, and the possibility of feedback. Secondly, we have to recognize the importance of an answer and the answer are really two different aspects of a health problem. So as you're exploring through our resources, we need to have, and we want to do this through partnerships with those who display our resources, you need to have a better understanding of why someone's looking for information. If your kid is bleeding now and you want to know what to do immediately, you don't want 3 different studies that explain coagulation factors across the lifespan. So you need to find not only the content specific that an individual's looking for, but also the motivation in the moment. And those displays, I think, will come through better public-private partnerships using our resources.
Rasu, you mentioned sort of the coordination that UPMC is now doing with payers and sort of the benefits of that. And I guess I'm curious to know, just to kind of press you on the flip side of that a little bit. You know, some patients in the Pittsburgh market sort of feel like they're now caught between these two behemoths as consolidation between payers and providers has occurred in that, and that market is very famous for that. And so I guess how do you, first of all, I'm curious to know if you hear from patients who feel like they're, you know, maybe had a health plan with, I think it's Highmark, but they had a UPMC doctor, and now they're kind of divided. So how do you, as an innovation thinker, you know, who wants to help patients, like how do you try to navigate that, and what do you say to those patients, and how is this health system going to address that?
Yeah. So it's a great question, and the reality of the region that we live in is exactly what you just described there. Having said that, you know, there's no better place than there to actually innovate around some of the newer care models, right? So we're a large provider organization, but the largest growing part of UPMC is also our plan, our health plan, with 3.5 million lives that we're actually covering. So when it comes to innovation, which I think was the crux of your question there, the way that we're thinking about this is we're trying to shift the paradigm from how healthcare has been for the longest time, which is very patient-centered. And as a clinician, it rolls off my tongue to say, of course we're practicing patient-centered care. Of course, that's what we're doing. But the newer reality that we're pushing for as an integrated delivery payer-provider system, living in that ground zero for accountable care, because there's so much activities happening in that area there, the way that we're looking at this is, how do we shift it from it being just about patients, and I say just with air quotes, to it really being about the person, right? Because at the end of the day, it's person-centered care that we need to be striving for, right? And it's a newer business shift, business mind shift, even to think about it from those perspectives. It really gets us to think much more broadly than, all right, you know, the episodic care that we need to provide to the patient who comes in because, you know, they're going through some illness, right? And it then it really starts bringing in capabilities, solutions, capacities for you to think about what it means to get that patient to be well as quickly as possible, you know, using all of the advancements in medicine and science and technology, but then to keep them well, right? Because at the end of the day, that really is the only way, not just for us at UPMC, but really as a health system across the country, for us to get to where we need to be, which is costs finally starting to go down, quality finally starting to go up. And so that's what we're pushing for, is through those lenses of moving it from a patient-centered to more of a person-centered approach to care.
So would you tell a person who feels like they're caught in this a little bit that, you know, this is like, sorry, this is kind of just how things, like, it's going to be a little rocky for as we innovate this, and this is just kind of the price of disruption, but, you know, we'll get to a point where it's actually going to be better? I
think what a lot of folks are realizing is that choice is good. Right? To have choices is good. To have competition is actually really good as well. And at the same time, you know, what they're also seeing is how we're actually invested in their priorities, right? Where we're providing for them the options in terms of all the great providers and hospitals and facilities, but also at the same time, you know, if we're covering for them in terms of their health plan or insurance, then what we're really motivated is to make sure that they are able to prioritize what their preferences are. And so we're doing this not just by talking about it, we're doing this with the innovations that we're actually creating, the ways that we're actually interacting with them. The level of satisfaction that we're seeing from the patients and the health plan members that we're actually covering is at an all-time high. I mean, there's a reason why all of that is happening. And I think, you know, part of the driver for all of this is sort of the newer care models that we're actually pushing forward with.
Just last question really quickly for all three of you. Everyone kind of in this room can speak the same language. How do you kind of break out of this room and get it across more kind of these innovations, these how sort of the direction this needs to head? Like, how do you kind of push it into the wider healthcare system? Because as one common theme has been, it's a pretty complicated system. So how do you kind of diffuse this out?
Well, I'll go first really quickly, but I think it's really important for us to capitalize on the fact that people are a lot more connected and engaged and leaning forward, leaning in than ever before, right? And I think one way to do this is through social media, and this is being streamed live on Facebook. I think it's important for us to make sure that it's not just all of us that obviously are convinced that this is where we need to go, but really spread the word, make sure we're able to activate others across the board and have them participate in this movement that we're part of right now. So social media, let's set the world on fire. Let's make sure that we do this collectively together with a defined and singular purpose.
I'm going to take a page from the UPMC playbook and say, make it invisible. So the National Library of Medicine increasingly provides our resources embedded in other resources. Through Medline Plus Connect, where people embed in electronic health records the kind of advice individuals need. So we cut out a step in the cycle. We need to make tools that are really useful. So the pathogen pipeline is really useful to a lot of people. And that's where our strategy will take us in the future. People will always read. This is important. But embedding knowledge into the point of action is where we need to go.
That's where that.
Yeah. That pyramid that Tom Ferguson outlined and is shown with the care between the care. The idea that how much time you spend in front of a medical provider, physician and nurse, versus how much time you spend by yourself or in self-care. That's the thing that you need, that the doctor, nurse, patient, everyone involved in health informatics, everyone involved in it needs to understand, because that's where you see the big opportunity is realizing that this is where we live, this is what we did, but that's how we need to bridge these. How do you create a better life?
Got it. All right, I will let you go. Thank you very much. I appreciate it.